Scleroderma Associated Muscle Disease typically, in our experience, affects the muscles primarily in the proximal muscles, including neck flexors and proximal muscles in the arm abductors and hip flexors. So most of our patients who complain of muscle weakness and we eventually diagnose with myopathy or muscle disease associated with scleroderma typically have that kind of pattern of weakness. So typically when the patient comes to the myositis center or at the scleroderma center, you will get a delineated workup to figure out what type of muscle disease you have. The workup typically includes, of course, a physician examining the patient to figure out what the pattern of weakness is, number one. Number two is usually getting muscle enzymes, which are the creatine kinase and aldolase. Those two are very important to determine, is there an inflammatory component to the muscle disease or inflammation of the muscles, so myositis, muscle inflammation. If those are elevated, then we think that there potentially is an autoimmune inflammatory component of the disease. Three would be to do an EMG or electromyography with nerve conduction studies, and that helps us to determine if someone is weak. It's very hard to determine, is it because the actual muscle is involved or is it because the nerve is damaged? So if the nerve is damaged, either the motor or sensory nerve is damaged, then the muscle cannot work in order to allow us to walk and move and do things. So that's why the EMG and nerve conduction is important. The fourth would be a muscle MRI is very helpful to determine basically if there's activity or damage, right? So if someone has muscle edema or muscle inflammation, we can see it on a specific sequence on the MRI that we run here at our myositis center. And last would be to get a muscle biopsy. The muscle biopsy can really dictate how we manage a patient, because certainly if we find evidence of severe necrosis of the muscle or a lot of inflammatory cells on the muscle when we look at it under the microscope, then we would be more aggressive about treating it. And we would also have a better idea of how to treat that patient because we know that certain drugs may work better for that subset of patients. Using all of these tests that I mentioned, the pattern of weakness when the physician examines you, the muscle enzymes, how elevated they are or how maybe they're not elevated, the EMG, the MRI of the muscles and the muscle biopsy, and the autoantibody, all of this. Now, we don't have to do everything in every patient, but that is kind of the general algorithm we use. That will help us determine if you have an inflammatory muscle disease that's associated with scleroderma, or is it more of a fibrosing myopathy, meaning it's not as much inflammation, but more fibrosis in the muscle that can cause a severe weakness as well, or is it a neuropathy or nerve-associated muscle disease, or a nerve that is being damaged that causes muscle weakness. So that helps us diagnose what exactly you have.